Hello, everyone. Welcome to our Institute for Brain Health and Dementia seminar series. I'm so pleased to introduce today's speaker. This is Dr. Keith Cole. He is an assistant professor in the Doctor of Physical Therapy program here at GW. Prior to coming here, Dr. Cole practiced physical therapy in the outpatient setting for nearly a decade. He earned a board-certified orthopedic specialty. He is currently funded by internal grants as well as from the National Institutes of Aging. Dr. Cole's research interests combine his biomedical engineering and physical therapy education by working with multidisciplinary teams that adapt emerging technology to examine the relationship between cognition, movement dysfunction, and community participation. He accomplishes this through real-world mobility simulations that involve movement while doing a cognitive load. I can say myself that I am one of these investigators currently benefiting from Dr. Cole's just genius and expertise. So take it away.
That's too kind. Thank you, Loretta. It takes a great team of people to do great work. So hopefully we'll continue to do that. So today I'll give more of the perspective of kind of myself as a physical therapist and the career trajectory that I've taken and where we're going. In this seminar series, we've heard quite a bit about kind of physical activity effects on brain health, on epidemiology of brain health, and even some in the last session on some activities of daily living and kind of visual motor mobility functioning through driving. And so really how I got into brain health and dementia is by starting by treating older adults that have had falls or that have fall risk. And so injuries in the older adults are really multifactorial, where falls cost the US healthcare system $51 billion a year. That's a huge amount of money. And about 50 billion of that is non-fatal falls. And so there's a multitude of factors that happen after somebody falls. It increases the risk of subsequent injury. It increases comorbidities like obesity and diabetes, and it decreases further community participation. And this is a huge issue as people over the age of 65 will be about 20% or 1/5 of the population by 2040, which is getting closer and closer. And so from kind of the physical therapist perspective of things that we usually work on is that there are a host of peripheral and behavioral changes that happen in older age. And so that's a reduction of the number of motor units. Type 2 muscle fibers decrease in cross-sectional area. So there's decreased force and power. There's degradation that happens at the neuromuscular junction. So the message for muscle to contract doesn't get across as well. There's slower cross-bridge dynamics, which means the muscle's contracting more slowly. Diminished proprioception, so decreased feedback to the brain about how we're moving. And alteration of the elasticity of tendons, so they lengthen more easily, which doesn't kind of allow the transmission of force from the muscle to the bone for movement. And all this results in altered force velocity curves, so the ability to produce force at different kind of slow and fast velocities, an increase in reaction time. So when something unexpected does occur, it takes longer to correct for that, and decreased and increased force variability, or not controlling kind of the muscle force that they're using as well. And there's even in older age, there's something else called sarcopenia, which is an even greater degradation of all this, where fat infiltrates into the muscle and the muscle quality is poor, and we actually lose type 2 muscle fibers and motor units, which makes it even worse. And then physical therapists even do kind of think about the brain, of course, because the brain is controlling all this movement. So age affects size and activation of neural substrate, where there's a reduced size of brain structures that aid in motor skill and executive function. And here in these graphs, we can see kind of the lateral prefrontal cortex and the changes in volume of the lateral prefrontal cortex as we age. You can see that, that really kind of decreases all the way, starting from age, 22, 25, all the way up to 90. And then the caudate nucleus, which is kind of important for motor function. And again, just quite a reduction in volume. But there's also a decreased availability of dopamine, which is a key transmitter for the basal ganglia for motor and cognitive function. And then as we're aging, the brain really adapts. The compensatory changes that happen are that there's an increased widespread of activation throughout the brain for both processing and sensory motor areas in order to try to maintain function. And so as I continue to learn kind of about kind of aging in older adults by practice, I kind of was digging more into cognition and aging because I was seeing that there is a relationship. And you all may know physical therapists tend to not focus on cognition as much as some other disciplines, but in the last decade, we really started to realize that it may be very important. And so there's two different types of two different buckets of cognition that we sometimes focus on: the crystallized intelligence, which is more of the world knowledge that continues to increase as we age. But there's also fluid intelligence, which is like speed of processing, attention, working memory, short-term memory and long-term memory. And those tend to decrease with age, as you can see with this kind of slope going downward. And then just with other movement aspects of aging, there's quite a bit of variability. So as you can, sorry, I'm trying to get, so you can see there's quite a bandwidth from this normal line for fluid intelligence. It does increase to about the age of 20, 25, and then kind of there's a mean downward slope. But if we're looking at change over time at different ages, there's extreme variability in here where some kind of have this increase, some have a very sharp decrease, but overall the trend is downward. So where that becomes somewhat interesting is this realm of kind of lower than normal, so in this bandwidth of where there might be some potential for further degradation and even kind of a diagnosis of mild cognitive impairment to all the way to dementia. And so not only physical health or risk for falls is important, but cognitive decline is also a really huge deal. And so 16% of individuals above the age of 70 years have been diagnosed with mild cognitive impairment, and 10 to 15% of those with mild cognitive impairment progress to dementia every year. And in both mild cognitive impairment and early Alzheimer's disease, changes in the brain may appear long before physical or cognitive symptoms appear. However, there's a lack of biomarkers that can determine which group will progress to frank Alzheimer's disease. And hallmark biomarkers for Alzheimer's disease, including beta amyloid plaques and accumulation, tau aggregation, and neurofibular tangles, although they do not necessarily reflect current or future functional, they really don't necessarily reflect current or future functional or behavioral status. Nonetheless, with all of that, by 2050, 12.7 million people are expected to have Alzheimer's dementia. And so I'll kind of wrap this back to fall trends for a moment. Falls are the leading cause of accidental injury and hospitalization in people age 65 or older. And 1 in 3 adults age 65 or older falls at least once a year. But kind of the intersection of falls and cognition is older fallers with cognitive impairments are also 5 times more likely to admitted to a care institution than older non-fallers without cognitive impairments. And so that really limits the ability of older adults with cognitive impairments to age in place. And so on this kind of graph, this is kind of a pictorial representation of different factors that go into fall trends, where there's changes with aging and chronic disease and loss of mobility, and then external factors that they've kind of identified as like floor surfaces and furnishings and stairways and things like this. But what if we overlay some cognitive aspects to that? What's the cognitive load of the external factors, like the number of people moving around or a different environment they have to navigate, not getting hit by a scooter on a DC sidewalk, or avoiding somebody walking and texting on their phone. And then here's the cognitive capacity, or as you saw that fluid intelligence start to decline, what are the resources they have to attend to each of those different items and do functionally well. And so there's been some really interesting seminal work in the last couple of decades that have shown, a relationship between different aspects of cognition and movement control. And particularly this has mostly been done in the upper extremity because it's very easy to measure, reaching to a point or to change the kind of visual field, or to shift the visual field to kind of adapt where they have to reach. And so Seidler's group has done some really fascinating work showing that kind of the decay constant of learning a new task is highly related to working memory capacity. And so those with a larger working memory capacity will decrease error more quickly, and those with a smaller working memory capacity will take longer to decrease error, where it takes longer for motor learning to occur. And then you already saw that older adults kind of have that decrease of working memory. And so this is kind of a representation of older adults versus younger adults and decreasing and improving their accuracy of a learned new motor task that's reaching. You can see they end up kind of at this similar endpoint. They all learned how to do the task similarly well, but it takes older adults a longer period of time to reach that accuracy. And then even this has kind of been translated into looking at whether or not subtle declines in executive function correlate to falls history. And indeed, Muir and colleagues found that a decline in executive function does predict 1 year history of falls. And even in a prospective study, they're able to show that executive function relates to outcomes of a balance intervention. So not necessarily falls, but how well they can learn kind of new or improve in tasks of balance. And so that's pretty interesting. So even cognition can really help us prognose on patients. So how does this apply to functioning in a busy environment? So limitations in community participation of ability have been shown to be somewhat related to many factors, but it takes increased cognitive resources to move when you have cognitive decline or neurologic disease. And this has been kind of, I think, shown more readily in patients that have stroke and multiple sclerosis and Parkinson's disease. It actually takes more cognitive resources to focus on moving. But that also results in a decreased amount of cognitive resources that are available to attend to the actual environment. And so then that causes fear of falling and self-efficacy, because they don't want to go into new environments because they're afraid of falling because they have to focus on moving. And when they do go out in the environment or do move, people with mild cognitive impairment have shown to have double the risk of a fall and 40% increase fall injury. And so that's pretty huge. And so we already kind of related back to those with cognitive impairments and movement, or those with cognitive impairments that fall are more likely to have to seek external help or not live in the home. So we want to keep them as healthy and in their home as possible. And so where did this kind of leave me thinking when I went towards research in clinical practice? So I wanted to further investigate the relationship between cognition and movement performance, and kind of really see how does motor performance change when cognitive load increases. And I'll get back to gait a little bit later, but is The upper extremity has been widely used because it's easy to measure kind of reaching to a point, or it's easier to measure to reaching to a point. And gait and gait parameters tend to be pretty highly variable. So is there a way to accurately measure a lower extremity movement that's not gait? So that we can get a sense of not just how the upper extremity is affected by cognition, but also the lower extremities, which we use, many of us use for functional mobility. So when I was doing my PhD at the University of Iowa, I was working with Richard Shields. So I'll give Iowa a little credit here. And this is an apparatus where you're able to actually do kind of a mini squat to push this rack and pinion system inward and pull it out so that a line on the screen would go up and down. And then a target would come up on the screen, and then the person would have to match that target as they come up on the screen. And so here, this is kind of a novel visual motor task where we have to use our lower extremities to match it or trace it, similar to what some upper extremities have done. And so then we took a cohort of younger adults, middle-aged adults, and older adults, so 20 to 39, 40 to 59, and 60 to 79 years old, and wanted first just to show that the motor performance and motor learning of this lower extremity movement was similar to what's been found in the literature in the upper extremity, to show that there is a transfer between how we control the upper and lower extremities. And you can see as we scale from younger to middle to older adults, and then go from a slower, lower resistance to a faster, higher resistance, there's a scaling of difficulty, or the error goes up when performing the task. And interestingly, error also goes up between the age groups. So these are statistically significant differences between younger, middle, and older age groups. So as resistance and velocity gets higher, then older adults don't perform as well. But there's also a quantity that we use called coherence, where since we were matching kind of the sinusoid, coherence is basically a quantity of matching a waveform, where zero is like no matching to it, and 1 is perfect matching of that waveform. And here we could see that younger adults really did much better, where they matched that waveform quite well across the different speeds and resistance. But middle and older adults tend to plateau in their ability. So this means that older adults are probably trying to match that speed and sacrificing error. And this goes along nicely with the upper extremity literature that we already have, showing the speed accuracy trade-off, and that older adults have greater error when trying to perform kind of a new visual motor task. So we felt, okay, good, we can kind of validate that this concept of motor control transfers to the lower extremity. So now we wanted to have a cognitive overlay. So we took just the younger adults and older adults, and we had them do that same task where they had to trace a line that comes up on the screen during that mini squat. Then we used a paradigm that was published by Song and Bedard from Brown University, where we would flash different T's on the screen, and the T's would be different colors and different orientations. And we call this a simple task, but maybe not so simple, is that as you're tracing this knee movement, you then have to count the number of one color and orientation that flashes on the screen. So it would be like amongst those randomly flashing T's and colors on the screen, you would count the upright orange T's only. And then at the end of the trial, you would tell us how many T's come up on the screen. And then we have a quantity of cognitive performance by matching that to the computer counted number, so the accurate number of T's. And then we would have a more complex cognitive task where they would have to count 2 different colors and orientations of T's that flash up on the screen. So it'd be like an upright orange T and an upside down blue T amongst the randomly oriented and colored Ts that flash on the screen. And so then they would have to switch between two different criterion for the Ts and count them together. And so we did do a 3-day protocol, but I'll focus on the first and second day here for the results. So we had a control group, and then a dual task 1 group and a dual task 2 group, or a simple kind of dual task or a complex dual task on top of the same motor task that everybody performed. And so they got 20 training trials in order to get as good at that task as possible. And then we did a transfer task where we would, those training trials were all at a set speed and a set resistance. And so it was at a medium velocity and medium resistance. And then we would do kind of the test where it was the gradation of low resistance, low velocity, all the way up to high velocity, and see how they could transfer their learning for that one condition to the other conditions of speed and resistance. And then we would bring them back 48 hours later and then do a retest to see, how they were able to perform on that trained task after, a period of consolidation. What we found was pretty interesting. So if we look at kind of the younger adults and then the older adults, where we have the control, so single motor task, no cognitive task overlaid as the closed circle. And then we have the open circle as the kind of counting 1 character, or the dual task 1. And then the open triangle as the counting 2 characters, which is dual task 2. Here we showed that it really took it, or a decrease in error or an improvement in accuracy took longer for those performing a cognitive task, but they ended up getting to the same endpoint. So similar to kind of the Seidler results for those younger results, or for the younger individuals. But interestingly, when we went to the older adult, here we see that the counting the single T or the dual task 1, they indeed did kind of do similarly to the older adults that were performing only the motor task. But really, those performing the complex dual task didn't improve at all. So they weren't able to really decrease the motor error component of this task. Up here, we have the kind of the cognitive results. They were able to reduce on a large part the cognitive error. So there might be some task prioritization there as well. But kind of the key of that is that when performing a complex cognitive task, or, if I were to relate it to something real world, a really busy environment or a new environment, the motor performance was quite poor. So another measure that can be used when thinking about cognitive motor dual tasking or doing a cognitive and movement task at the same time is by comparing a person's ability to perform the same motor task under just a motor task or a motor and cognitive task. So when we subtract that, we call that a dual task cost, or sometimes you'll see called a dual task difference. And so indeed, we did that in this study too. So no matter what training group we had the younger and older adults then cross over to do the single motor task people then did a dual task. And then the people that trained with the dual task then did a control task so that we could subtract the performance. And here we could see the people that can perform the controlled or trained under the control task. They had a much higher error when they moved to the dual task versus those that trained with the dual task moved to the control task or the single motor task. And this was even more profound in the older adult group. So those that performed with the control task, those that trained with the control task then had a much higher error when they moved to perform the dual task versus those that were exposed to the dual task that transition to the control task. So what all that really means is that, although the older adults that didn't learn how to perform that motor task very well. You know, when push came to shove, that exposure to a dual task was somewhat protective when they had to cross groups. And so there may be a paradox in which, you know, the context is kind of important, where in order to perform kind of in both high and low cognitive load, there has to be some exposure to moving with a cognitive load. And so that really is going to take a lot more investigation to kind of dig through. But that paradox may be quite important for physical therapy and for preventing falls. And then in the study, we also use the NIH Toolbox cognition battery to examine different components of cognition. And when we looked at improving performance or decrease in error and working memory capacity, we didn't find a huge relationship. We did find that in the control group, so the single motor task in the younger adults, there was some explanation of variance from working memory capacity. But what we really found was that in both the younger and older adults, a measure of executive function of the flanker task or inhibition and attention explained for between 72 and 90% of the variability in final error of that skill acquisition. So here, like some other studies, were showing that executive function really kind of moderates improvement in performance of dual tasking. So from this, we found that healthy aging is associated with altered motor learning and performance in weight bearing, where there is an increase, well, with an increase in age, there's an associated progressive change in the speed accuracy relationship. The lower extremity is similar to the upper extremities. That cognitive load slows motor learning. That training with a cognitive task in older adults results in greater motor task automaticity than not having been exposed to the task at all. So there might be some kind of protective benefit to that exposure. And that executive function predicts about 80% of the variability of motor performance when performing a dual task. And so that's all great, but then we don't have a comparison to actual functional movements yet. So we have to continue to do more studies. And one limitation of this device, not only that it takes up, is that it takes up a whole lot of space and requires quite a bit of engineering. And so I was really looking for a way to make this more portable and getting it into basically more clinics and more homes. And have something that's scalable to get really great data. And so one way that we thought of doing that is by using a device that does skeletal tracking that just hooks up to a computer. And so the Microsoft Kinect version 2 is a great low-cost way to do that. And it's been validated against some gold standards like a Vicon or a 3D camera system to show that it does very well measure movement of the lower extremities like the hips and knees. And so it created kind of a program that would, let's see. Sorry, the thing isn't coming up. So basically we created hooked up the Kinect to a computer and a TV screen. Sorry, I don't know why this isn't playing. Okay, well, I'll just explain it. So, so this depth sensor comes up, and then I'll step back to the blue area so that I standardize how far away from the screen I am to have a similar visual cueing for all subjects. And then a skeleton will kind of go over my body, where there'll be like big ellipses or dots on my hips and knees. And then a target will come up on the screen. I have to match my knee to that target to kind of move my knee up and down like I'm marching in place. And so the advantage of this is that, really when I'm moving in place and having that skeletal tracking kind of matching to the dot, I can get some instantaneous feedback compared to walking, you're just kind of moving across space. Here now we have kind of instantaneous feedback of whether or not we're performing this movement at the right pace and tracking on target. And then we can also provide some really accurate delayed feedback where we give a quantity of error, just like kind of the upper extremity studies and that mini squat study. And then we can still do some transfer of tasks by altering the speed and things like this, and still do cognitive task performance. So we get really many of the same benefits from kind of the previous device, but now we can make this more portable so that we can do further investigations. And so in this, we use a similar paradigm where we could do 20 training trials at a set speed of the target and transfer that to different speeds of the target so that we have a transfer of learning task. We can have similar T's flashing on the screen to do the same thing. And then now we can also integrate EMG or electromyography to look at how the muscles are being fired and look at neuromuscular strategies as we're learning. In this next phase, we're including clinical measures of mobility, like a timed up and go test, where you stand up from a chair and walk 3 meters and turn around, come back and sit back down. A timed up and go cognitive, so a dual task timed up and go test. You can do gait measures of a 10-meter walk test, balance measures of a single limb stance, and then all that using an instrumented pressure sensitive mat called the Xenomat to get an instrumented further details of gait and mobility. And then again, using the NIH toolbox cognitive battery and Montreal Cognitive Assessment to look at domains of cognition and risk of mild cognitive impairment. So this study is ongoing, but we have some unpublished pilot data and show kind of similar results for the 20 training trials, where we have kind of a single motor task error across 20 training trials. And then that same kind of counting 1T, where we have a similar decrease in final motor performance. And then the more difficult counting 2 different T's and then decreasing down to a similar, slightly greater, but similar error in 20 training trials. And here in this paradigm, we're actually kind of using, and yet unpublished, but quantity that combines both motor and cognitive error. So we're taking the motor pixel errors, or the kind of difference in the position of the dots on the screen, and multiplying that by a 1+% error of cognition. And that way we can have sort of a combined error, so that if someone is prioritizing the cognitive task, we're not looking at the motor task and thinking that it's very different. Or if vice versa, if somebody is prioritizing the motor task, it might look really great, but the cognitive error is very off. And to be honest, this is kind of a huge hole in some of in the mobility in the dual task gait literature, is that many will just report on the motor task performance or the gait parameters and not report on the cognitive task, which leaves us to think, what are they prioritizing? And was there a similar effect from that cognitive task across everyone? And then, putting in a little bit of pilot data, we're able to overlay a person with mild cognitive impairment performing that same kind of task, but now they're doing dual task 1. You can see this combined movement cognitive error is pretty massive in the beginning for that person with mild cognitive impairment compared to the cognitively healthy individuals. But eventually they do come down and have an error that looks more similar to perhaps the dual task 2 group. And remember, that's a combined motor and cognitive error. And so when we kind of look at just the motor error, we get this interesting picture where really the decline in error does look, from a motor standpoint, does look very similar to the dual task 2 until kind of much later, where they by the end they do reach a similar motor error. So there might be some interesting pieces of prioritizing one task versus the other for an extended period of time, where others might switch between each of the cognitive and motor tasks. So attention and inhibition and task switching, which is executive function. And so really we have a couple of grant submissions out that we're hoping to determine if this cognitive motor stress test, or having them do kind of this dual task and can really identify mild cognitive impairment. So a behavioral task that identifies cognitive impairment. And to see if biomarkers for MCI and dementia actually relate to performance on this dual task test, to see if those biomarkers are correlated. And then to investigate if this non-based dual task is superior to a gait-based dual task in early identification of mild cognitive impairment. So my bias is that you can't, or that gait is very variable and it's difficult to measure. So it's something that's more easily measured, going to identify mild cognitive impairment, even though it's not exactly perfectly functional like gait. And then are there sensory motor biomarkers that might be helpful in identification of early cognitive decline and to prevent falls and injury, which would be huge both for the individual and for cost. So I'm going to wrap back to, so why not gait? So gait is altered in many different ways to be used functionally. So we speed up, we slow down, we turn, we pivot, we navigate. And in a real environment, there's many different levels of cognitive load. So what's really the right load, and how should we be measuring gait? Should we be measuring gait on, in a really closed, quiet environment over a very short walkway that's instrumented? Should it be in the clinic where we have a normal amount of busyness, or should it be out kind of in the real world where there's multiple tasks going on, like carrying and talking and searching and things like this? And so we've kind of sort of scratched the surface with gait and dual task gait. Where some clinical measures of gait have actually been shown pretty promising in detecting mild cognitive impairment. And so sorry, I just realized I messed up the order here, but in a 10-meter walk speed, sorry, so when looking at a 10-meter walk speed, so just gait speed timed walking over 10 meters, and when looking at a timed up and go test, the time of those tests were associated with mild cognitive impairment, and those with mild cognitive impairment that would fall versus those that wouldn't. So these clinical tests might show some indication there. And interesting, in this same study with Hada et al., they showed that the turning aspect of the timed up and go test, or kind of returning and turning to sit back into the chair, was highly indicative of those with Alzheimer's disease that would fall. So that turning aspect might be a little bit important. And then there was a meta-analysis that showed that that gait velocity was slower in those with mild cognitive impairment, with a Cohen's d of about 0.7, it's decent. And then when tasked with dual tasking, gait speed slowed even more in those with MCI when they had to count down from a number by 7, so giving them a serial 7 subtraction task. And then kind of that continuing on kind of later in studies after that meta-analysis was published, there have been kind of some similar results where dual task gait was slower in those of mild cognitive impairment, but in this study they didn't find a difference in single task gait speed. And again, executive function or executive attention performance explained about 24% of the variance. So executive function kind of parallels this gait speed or explains some variability for it. And then gait velocities during dual tasks may differentiate MCI subtypes even. So where slower gait had a higher dual task cost in amnestic mild cognitive impairment versus non-amnestic mild cognitive impairment. And that might be important because some feel that those with amnestic mild cognitive impairment may have a higher likelihood of progressing towards Alzheimer's disease versus those that are non-amnestic. And then beyond clinical measures of gait, some of the instrumented measures of gait, so like walking over the pressure sensitive mat or 3D camera systems, may have increased detectability of movement dysfunction or gait differences between cognitively healthy individuals and those with mild cognitive impairment and Alzheimer's. So one measurement is gait variability. An increased gait variability predicts future risk of cognitive decline or dementia in initially non-demented older adults in a few studies by Verghese. And again, with that same research group, those with poor dual task gait have a greater functional decline in the next year. And then some other more recent studies, or similarly recent studies, have showed that step length, stride length, and quality of gait are closely associated with balance and ADL performance in those with dementia. So getting into that kind of functional realm of ADLs. And then gait speed and stride length were significantly different in those with mild cognitive impairment compared to cognitively healthy individuals. So with these, gait seems kind of promising. So why not gait, right? So here, kind of some thoughts on why gait is a little bit problematic, perhaps, or we need a lot more studies on gait and the intersection of cognition and its predictability for mild cognitive impairment and dementia. So current studies may detect a statistical difference, but many times effect sizes are small and aren't kind of the same or translatable between studies. So really there's no cut point to differentiate cognitively healthy, mild cognitive impairment or dementia. So it may take some determining some cut points and applying to a new prospective group of individuals to look at the receiver operator curves or predictability. And then our instrumented tests of gait more informing the clinical tests? Do we need kind of those aspects of gait variability or precise step lengths? Does that function into the equation, or can be something as simple as speed of gait in the clinic? And then what cognitive task is most revealing of function? So if we're really worried about kind of falls and injuries in the community, is serial sevens or subtracting 7 from a number really the best or most optimal cognitive task to test with, or are there different levels of cognitive tasks that we should be using? How far should they walk for a valid test? You see this really short Xenomat here. Some studies have shown that it takes over 200 continuous cycles of gait in order to really detect a clinical difference between other neurologic subtypes. So is walking on this kind of short 4-meter platform good enough? And then does turning provide additional information, or other modifications of gait that we do in a natural daily life? And does that play into the equation that might be fairly important, such as the one study that looked at frank Alzheimer's disease differences? And so to kind of summarize kind of that portion of it, detection of mild cognitive impairment is important for early diagnosis and potential intervention to reduce falls and improve balance. But subtle changes in functional performance, such as gait, has been described in mild cognitive impairment. And motor and cognitive motor function may lead to motor errors and mobility tasks like falls, but there's still a knowledge gap if there's a really great behavioral biomarker that can differentiate between healthy aging and Alzheimer's disease associated decline in both cognition and functional mobility. So we don't have that set biomarker yet. We have good indications, but haven't gotten there quite yet. So maybe one way to approach this is kind of, again, or kind of coming to our ICF model, or International Classification of Function model. This is one that was done for stroke, but I think we could look at that for aging as well. We have walking speed and walking endurance and walking in different terrains and the timed up and go test. And those are some of those activities that I talked about today And that might be interrelated with muscle strength and kind of movements and things like that, which we talked about today. But maybe this participation aspect is somewhere that we can really focus on as well. All these interplay into being able to stay a functional member of our community and to interact with our environment. So this gives us some idea of a potential way to alter both cognition, complexity, environment, and task complexity, all those things that kind of are unknowns about gait. So luckily, technology is advancing really quickly and making certain wearable technology that we can use to measure gait a lot cheaper and a lot smaller and more readily available. And one of those potential solutions might be an inertial measurement unit, or this kind of really small device that you can place on the body to measure acceleration, angular rotation, and to get precise parameters of gait. And so there are many different groups looking at sort of continuous walking monitoring using IMUs, and some are IMUs that are in phones or in like Apple Watches or other devices like Fitbits. But activity varies a whole lot between individuals, and it varies between days and between weeks and months. And so just continuous kind of activity monitoring may not be the best participation that we're measuring. But maybe there's specific IADLs that we can look at. And I think Dr. Babulal really kind of talked about this nicely, is that IADLs really combine different motor functions and different cognitive functions together in different environments, which really gives us kind of some nice cognitive complexity overlay to these, to the capacity of cognition and to the capacity of mobility. And so one study that Dr. Babulal last time highlighted that I think is really interesting is that even in a pandemic, some instrumental activities of daily living are really important to older adults. And so one that I know that I talk about a lot in the clinic, and I've talked to other clinicians that talk about, is food shopping. And so grocery shopping is extremely important to continue to do even in a pandemic, and most people do it. And so in the clinic, we talk about, navigating busy environments, that's grocery shopping; about carrying objects, that's grocery shopping; about reaching. So we talk about this, this environment, or this IADL, quite a bit. And so, so right now we have a funded study looking at wearable technology to examine grocery shopping in those with MCI compared to healthy older adults. So the idea at the beginning here is to standardize this real world task of grocery shopping and require them to go through kind of a grocery store that we built, and to retrieve specific tasks or specific items on a list. And then we'll use machine learning to do a couple of things. One is to identify each activity that they're doing. So walking, carrying an item, reaching down, reaching upward, turning around, and things like this. And then extract different components of that. So we said gait variability was important for some instrumented measures. And so we can look at gait variability of the straights. We can look at speeds of turning. We can look at jitter. We can look at velocity of the center of mass during reaching or turning. And then again, to use kind of machine learning and to combine all these different factors to see, is there a combination of these motor cognitive factors that are more sensitive to mild cognitive impairment, and can we track function, cognitive, both cognitive and physical function over time? And so we're just starting on this study, and so we hope to have results within the next year or so. And then just kind of a fun picture at the end. This is kind of our grocery laboratory, and some DPT students that helped the final touches on some of the aisle signs and signage for the grocery store. So this is where we will be kind of doing kind of that study. So hopefully this gave kind of a caption of sort of the intersection of physical therapy and brain health and dementia. and kind of the process that kind of I'm going through, looking to see how we can better detect and support those with cognitive impairment. And of course, it takes kind of a whole team of people, both past and present. So thank you all for your contributions and collaborations. And if anybody does have questions, be happy to field any.
That was wonderful, jam-packed lecture. Let's start with the question in the chat, which goes back to the kind of the the data from your own laboratory toward the front or the middle of the talk. And so, well, excellent work. Yes, of course. The question is, did you stratify on visual acuity in addition to age on your cognitive motor task experiments?
Yeah, great question. So we excluded those without normal or corrected normal vision. So we didn't actually do a Snellen chart, but we did exclude if they didn't have normal corrected vision. Also excluded colorblind individuals so that they could detect the difference in colors. Now, interestingly, I am colorblind and I can detect the difference in colors, but if you're using, as we age, our color acuity also diminishes. So I wanted to really be sure that that wasn't a factor. Great question.
So I'm always intrigued about the size of the error bars in any data pertaining to older people relative to younger people. And so it really, many times, I'm not going to say it inhibits our ability to detect change or improvements, etc. But maybe you can comment on that. And it's not just in your work, it's in my work. It's a response to, an oral glucose tolerance test, or there's just more variability of response that we have to deal with.
Yeah, 100% agree. And that's going to change, how many subjects we need in each study and effect size, and which is why maybe just P statistics aren't kind of the greatest way to go. Why we can use other measures of certainly MDCs, minimal detectable change, and looking at standard error ranges, or confidence interval ranges. And I think that helps. But at the end of the day, if this ends up having huge variable error and the ability of older adults to decrease their variable error, then maybe it's not the right measure. So if you need 1,000 individuals to decrease your standard error, maybe the test isn't sensitive enough. So, I guess we'll have to continue to watch that.
Or it's too sensitive, right? It picks up this incredible variability. I think about heart rate variability, right? And the differences between young people, old people, but disease and not disease. So I just think it's a quandary.
Especially in human subject research,
yes.
it's and that's probably why GATE is a little bit, why I'm hesitant to fully double down on GATE is because of that variability. Are we going to be able to find that cut point? I'm not sure. If we can, that would be lovely. For PTs, it would be, at least.
Oh yeah. I have a million questions. Are there other questions before I dominate? You can yell out or put it in the chat. So one of the things I really like about your work is it does indeed transverse the public health spectrum, right? Clinical, laboratory, and everyday physical function. So how do we correct or even prevent? What's the best strategy with regard to physical activity, say, in correcting some of these deficits or preventing future decline? I think you got the message across that physical activity is important for muscle function and brain function. We know that, but what type of activities should be stressed?
Yeah, that's the trillion-dollar question, right? And I think Kirk Erickson did a really great job of kind of describing a repeated muscle contraction as the sledgehammer to fix everything, right? It creates an endocrine response that affects the brain and the body, right? So now it's
The
like,
brain blood flow.
right, and BDNF, the VEGF, kind of those kind of exciting mediating factors, and irisin, and all, we can go on and on. But I think dose and dosage and type is going to be really important. I mean, I know the American Heart Association recommends 30 minutes, but it looks like from the brain health literature, it's looking to be more like 45 minutes, or it takes a greater intensity. So I think we're still teasing out this piece of is it interval training that creates periods of really high blood flow and high muscle contractions, or is it a repeated, constant, moderate, or are both great? And then what kind of cognitive overlay do you need if you want to, or should you have, to optimize function, not just from exercise, but from a functioning mobility standpoint? So, I mean, I'll tease kind of your brilliant idea, which is interval walking training with cognitive training at the same time, right? We have studies that are looking at doing aerobic exercise to prime the brain, to do cortical priming, and then do cognitive training right afterward in order to enhance the performance, or vice versa, doing the cognitive training followed by aerobic exercise in order to evidence shows that helps to consolidate that learning. But what if you're doing them intermittently at the same time? So it could be as simple as exercising in a complex environment. I mean, I think that might be really interesting to see, if it provides greater benefit than just a sledgehammer of a muscle contraction. Is that too gray, or does that answer?
Yeah, no, that's great. I've always thought of trying to do a ballroom dancing intervention, right? Because think about learning how to ballroom dance with a partner.
And I've seen plenty of studies that look at ballroom dancing and yoga on balance and overall health and function mobility, but I haven't seen one that teased out that cognitive piece yet. So I'm not sure about that. But certainly staying moving in complex ways helps your functional mobility. I'm just not sure if it's teased out in our kind of literature for that, the cognitive piece of it, and risk prevention. That's why I love this group so much, is it makes you think about everything outside of your spectrum as well.
Exactly. So, I agree totally. Are there any other questions for Dr. Cole? All right. Well, once again, thank you everyone for attending today's seminar, and we look forward to then the next one. And yes, you got a thank you in the chat. All right, take care, everyone.
Thanks, everyone. Thanks, Laura.
Have a good week.